Good afternoon. Thank you so much for the presentations. I've got a question. I can't remember who mentioned it, a study about asthma prevalence in Cameroon. Was it you? Okay. Or, could you tell us a bit about your findings? How does that relate to asthma prevalence in the region? And how does that compare to the continent more broadly? It would be interesting to sort of learn about any unique factors that are maybe driving asthma prevalence, especially since it's something that my understanding is that you're only just starting to investigate it, and so it's sort of been underground and hidden for quite a while, so it'd be interesting to write about that if possible. Thank you.
Thank you very much for your question. Yes, with Mr. Acheri Dikun, he actually went to schools, different schools, especially we focus more on the youth. So that's why the sample size for the youth were higher than that for elderly people. So we went to youth, to schools, and studied on the prevalence of asthma. So we asked questions and we use those statistics now to come out with the prevalence of asthma in Cameroon. So it was more in schools that we studied it, and that's where we got the information.
Yeah, just to come in, I understand the question as the principal investigator. So when I did this study, Lisa was still in school, like really lower grade. Yeah, so this was in 2018, 2019. So it's a self-reported study where we use passive consent to get into schools, to get to parents. So technically what is happening is that this is a global asthma study where the model is representative. So for example, if I give you the prevalence, what she was showing, in children, 6-7 years, 1.8%, in adolescents, 13-14 years, 5.3%, and adults, 3.0%. So you might be asking yourself, why there is this difference between asthma in children, adolescents, and adults? Asthma is a complex issue where during this study, one thing we deal with almost 20 variables which live from genetic, environmental, physiological, and what have you, psychological. So what happens is that explaining these trends, like the study we did in Cameroon was focused in Yaoundé, but it's representative of the country. For example, if I model this data I'm using is representative even of the whole of Central Africa. If you go to Nigeria and do this study, you will see asthma being smaller in children, 6-7 years, being higher in adolescents, and being lower in adults. There are several factors explaining this. And one of them, air pollution. This is why I got interested in air pollution, because when normally, if you're a medical doctor here, you know, they'll say asthma, one of the risk factors you think about is smoking cigarettes. But from this study, we noticed that school children, 13, 14, were not smoking a lot in Cameroon. And we were asking, but why is it that the prevalence of asthma doubled what was for children amongst this age group? There are several issues. I'll explain one. When children are growing up between the years 6-7, almost all asthma is genetic. It's not causal. Asthma is either genetic or causal. It means you can be born with asthma. These cases are always very few. They come from parents. The second risk factor is that the children get exposed sufficiently to pollutants before they get at the age 13, 14. And how do we explain this in law and in settings where I come from? In our homes, most of the air pollution comes from outdoor, not indoors. This is something that you will not understand how it works. Most of the air pollution comes from outdoor and not indoor, because the only source of air pollution indoors is the burning of biomass fuels. But why is it that so much pollution is happening outside, is indoor? It's because air pollution doesn't have boundaries. If we look at India, for example, we notice that when they burn during the season where they burn, you see the smoke moving from the area where it's happening to really distant area. And if you were in Cameroon, I don't know if it's the same thing in London. If you close this room for 1 week, seal it. You come inside, you meet dust on this table. I don't know those who have visited Africa or the areas where pollution is really high. I don't know if it's the same thing in London. Like if I close this room and come 1 week after, I'm going to meet dust on this table. It happens always in Cameroon, no matter how you seal. It's to tell you that these children, they inhale the particles. One of the things they inhale are carpets. We call them carpets, where we are. So this product on the floor here, it's a very big source of pollution for children who are creeping, like less than 5 years. They inhale so much dust because they play on the ground, and the air pollution that comes from outdoor, it settles on the floor, on these carpets. And that's why when I was doing my study, parents were very happy because I told them, if you have children creeping, remove the carpet until they start walking so that there will be level where they don't inhale the pollutants that affect them. This is one of the reasons why you see this gap between children and adolescents. And also, as physiologists, there is a way of explaining it. There was also a disparity even in the prevalence of asthma amongst male and female. So there is this kind of gender issue in asthma where you find asthma being more prevalent in children, adolescents, the boys, than the girls. Then when you get to the age 13, 14, it becomes more in girls than boys. So Lisa is here. It's not a testimony that boys could be there. During my working with asthmatic, I worked more with females who are asthmatic than males. But when I was collecting my data, I discovered more males, 6, 7 years, who were asthmatic. So this trend is something which is common in the whole of Africa. So if you pick my study and look at that trend where asthma is less prevalent in children 6, 7 years, more prevalent in adolescents. And this is why air pollution and climate change came in, because it's so difficult to explain why there is this big gap. Meanwhile, we have all the sources of pollution being a major problem. So I don't know if I've answered your question, but this is a global study that gives standards in terms of how you explain why the prevalence of asthma is really low in children, high in adolescents, and low in adults. And one of the things that we discussed during this session was what is the cost? And one of the reasons why air pollution, why the prevalence of asthma dropped in adults is because when adults start working at the age of above 18, they have money to treat themselves. And they neglect their children. So the prevalence of, there is something about stigma. So when we did this study, we noticed air pollution, we came to a conclusion that air pollution and stigma were the conditions that were driving the prevalence of asthma in Cameroon, because asthma in itself is a disability that some parents, some families don't accept it. In my context, the way we are speaking here, it is something sometimes like a taboo. They exclude those who are having the issue, and it becomes a big problem. And this is, the children get neglected. And when I was collecting my data, I have children coming to me, please, can you help me with a Ventolin, with an air? So they will come up to me to ask this. So Shweta, I don't know if you want to come in.
No, not as detailed information as Elvis you provided, but there's one very interesting study from India among asthma prevalence in school children, and this is a study that was done in 3 cities, New Delhi being one. And so New Delhi was the most polluted city out of the 3 cities, and the other 2 cities were less polluted. And there was an the interesting part of the study was that it looked at obesity because of air pollution. And so the drivers of asthma were air pollution, and air pollution induced obesity was also driving asthma. And the data was so grim from New Delhi. The data was almost like, and these are lung functions. These were not self-reported asthma, but these were like doctors going to schools with consent, doing lung function tests. And 1 in 3 child in Delhi has asthma. So it's almost 30% incident. And there is a follow-up to that study most likely going to come out hopefully this year or early next year.
Okay, thank you very much. I don't know if there are any questions, but I'll go to the app. There are several questions on the app, and I'll begin with the first for Shweta. Yes, as an air pollution campaigner, what type of air pollution research, health research will you most like to see? That is, what questions would you like to have answered? Michael?
Wow, I mean, this is almost like putting out a wish list. But I think the core in air pollution research that I have learned from my experience and what I keep repeating is that we really need to factor in community and community needs in designing research. And the reason why I'm emphasizing on this is because with a shared ownership with the impacted community, there's a good chance that the data from that research will be translated into advocacy and action. I mean, there is a lot of information, there is a lot of evidence. I don't think that we have to repeat, and I mean, anybody needs to be, hopefully, I'll be shocked if somebody comes and says, oh, air pollution is fine. I don't expect to hear that. But despite all of this data and this information, why do we see such limited action? And one of the reasons is because the siloed nature of this research. So I think before deciding what kind of research we need to identify who needs that research, what will be the strategy to implement or translate that research into action, and then come back to the question of like, okay, with these factors in mind, then decide what kind of data and research is needed.
Thank you very much. As we know, evidence is very important, and that's why such questions, who should be doing this research? I came working on research in like looking at clinical issues where I'm a biologist, but I felt like nobody was speaking because there is a problem of urgency. What if the problem is urgent? Who should be taking action? So this is a question we need to ask ourselves, even at individual level. I have a second question here. Are there any global sources of funding that countries like Cameroon can access to help with the energy transition that will have core benefits like improve indoor air quality? Lisa, I don't know, you coming from Cameroon, do you feel like there is sufficient funding, or do you feel like there is no money to address the issue of air pollution, to really bring solutions that will help children with asthma and they are already vulnerable? Do you feel there are solutions and the funding?
Actually, even if there are funding, our government don't really see the importance, like the impact of air pollution. It's not really a study that that is really considered in our country. They don't really see the impact. So even if they have, but even they have fundings, that is something that we really have to improve, like the knowledge. Like we don't really have the knowledge of air pollution in our country, and so that will really be very great. Like improve on the knowledge of people don't really have the knowledge of air pollution in our country and its impact on asthmatic patients.
Yes, so Lisa is bringing up clearly in a simple language where we are in Cameroon, because the feeling is that air pollution globally is a problem, and the way the response is at country level is different. Yes, because I travel a lot, and in every country I try to see what is happening and how the actions are being taken. It's how much political will do we have on this issue? And when we come to a global climate and health summit where, for example, the government is giving importance to climate change, but the drivers are not understood, like air pollution is a problem, and it's what we have been bringing in with APILAF, where Lisa is. We are trying to make government to understand this, and one of the actions we have been using is acknowledging the International Day of Clean Air for Blue Skies, because governments, as us, they recognize United Nations systems and organizations because they feel this is where funding will come from. I'm just trying to make you understand that once UN systems like the WHO does not take air pollution seriously at country level, our government will not take action because they are driven by guidelines, policies. For example, when you say air pollution is a problem, you need evidence, and our government has been responsive. Like when we began this work with Ministry of Health, we have a collaboration with Ministry of Communication. They actually wrote, the Minister the Minister of Communication wrote the Minister of Public Health in May after the WHO conference on air pollution and health, and he wrote another letter to APILAF, my organization, committing to communicate on the impacts of air pollution and climate change on health, which this is just about advocacy. We need so much of advocacy because government is still to understand the problem and is happy to take action but needs more understanding on the problem. So I don't know, I'll answer if there are any questions from the public. We are happy to. Yes, perfect.
Thank you for your presentations. They were great. I'd love to hear from the three speakers. In sort of your experience, what have you found that has actually been detrimental to positive impacts or interventions in the experience in the countries that you've worked in? Like, what actions have been particularly detrimental that were actually potentially supposed to be positive? Yeah, I don't know if I captured that, but do you get where I'm coming from?
Yes, yes. And I think there are plenty of those examples. Because unfortunately, this is my experience from India, that every time I go and speak to a city corporation about clean air or clean transport policies, they'll say, show us what London is doing. I mean, London is actually a good example. But for many times it was like, oh, we want to emulate some other country, some other city somewhere. And instead of focusing on what the local solutions could be, it's more like, give us a template, give us something from somewhere in the global north, we will do it. And those kind of solutions are very, very detrimental. I mean, there is a lot to learn from various experiences, but if we are not contextualizing it and understanding the nuances of that community, we are actually, and then what it does is that those solutions fail, bringing back to the policymakers saying, nothing works. And that sets in motion years of undoing of the work of, raising awareness that there is an urgency to act. I know that somebody from the crowd mentioned about these money incentivizing clean heating, building processes. India tried to do that. I mean, we're talking about 1.4 billion people. Tried to do that with moving away from solid fuels to gas, transferred money in people's banks, very novel idea, but in a situation where people are desperate to put food at the table, clean cooking through incentivizing through money schemes would not work, did not work, failed, right? So I think there are really good examples to learn, but unless we contextualize it, it's not going to work. And I feel that's where the missing link is. That's where the effort should be. And that's where the least amount of intervention is right now.
Yeah, thank you very much. Let's move to Ebba.
No, I just want to build on what Shweta was saying by contextualizing the problem. And I think in the EU, when we worked on the Ambient Air Quality Directive, we mainly worked on things like mortality. It was like the 400,000 or 350,000 people that died from air pollution each year. But when it's important that in every context to see what is important in that setting. If for some people it is more the child health that is more important, or it is the unborn child health, because that is something that people can come together with. And we worked for a long time with ARI, which is a medical association in Ethiopia, how to communicate air pollution. And then we realized that most of them came from infectious disease. So when we could translate the air pollution into how many particles it was in the blood, they could envision it, because that was something that was natural to them. So I think it's same as conceptualizing it and putting it into context would be.
Thank you very much, Ebba. I don't know if there are any final questions. Yeah?
Yeah, there's a question to Professor Ebba about your work in Adama and then other places where you have engaged the community to actually go out and help collect data on air quality. I wanted you to comment briefly about how sustainable you think that activity has been after you finished with the project. Is it something that you think is viable, and should we be promoting citizen science through that kind of activity to help us collect enough data, particularly in the global south?
Thank you. That's a very important question. I think getting the citizen engaged, which are fundamental. I mean, we could never have put up 40 monitors if we didn't have the society with us, because many of them was put up at people's houses and they had to guard the monitors. But I think for it to last longer than those weeks where we are there, we need also to have the local researchers involved in this and the local doctors involved in this project, because they are the ones that are going to stay there in the ground and talk about and the project and continue talking about air pollution. So getting the local PhD students and doctors involved, I think that is key.
Yeah, thank you very much. I'll have just one question each. We are almost going to the end. I'll have just one question which can be answered in like 30 seconds or 1 minute maximum for each of our speakers. The first one will go to Lisa. How do we ensure that vulnerable or low-income communities are not left behind in the push for cleaner air and climate resilience? So this is to see what can we do for as an asthmatic patient? What is your one thing that when you live here, you feel people here can help support those who live like you in your countries, or when you go back home?
Thank you very much for the question. I think it start with advocacy, like speak about it, talk more about it, and let people know about it more. And specifically in my country, Cameroon, what measures can we help to help the vulnerable countries? If mostly by, let me say, like focus on children, like I spoke about advocacy, and also even possible fundings too will be very helpful. And let's bring more of these conversations to the vulnerable countries. Like, thank you. Like what I'm saying.
Thank you very much. Vulnerability is about cost. And I'll come back to Shweta, where we are trying to feel the cost. How do we make the balance of the cost? Because I engage very more. Why did I got focused with Ministry of Communication when I was working on air pollution? Is because we have this collaboration with Ministry of Health, where they told us we are overwhelmed. We need other ministries to support us in this work. And climate change and air pollution fall in one of these areas where the Ministry of Health, Public Health is overwhelmed with issues. Other issues, I'll list some of them. Malaria, they are pressing issues. Polio and all of this. I'll come back to say, Shweta, how can lived experiences and community engagement be better integrated into public health campaigns around indoor air quality? As a campaign lead, I feel that the community, the way we engage with our community to understand the problem and how the response come, because we know how, for example, mayors, the role they play, and how councils, because there is this disconnect between how the community engage with government to understand the problem. Do you feel vulnerable people can take the lead in pushing this forward?
Absolutely, that goes without saying. But more importantly, I think while the community has the lived experience of pollution and harm that they can describe, we've also seen that when it comes to health harms, it's not somehow in the policy space or in the litigation in the courts, it's not enough to have your lived experience. You need the expertise to validate and especially when it comes to health harms. So in addition to vulnerable communities articulating their lived experience, we really need the health professionals and the health community with the evidence that they're seeing in their clinics, validate community concerns and help them enable their advocacy goals and achieve their advocacy goals. Normally in the most environmental health debates, you will have the courts, you will have the lawyers, you'll have the communities, you'll have the engineers, the project proponents in the conversation. The missing link is the health community. And their presence is absolutely important in advancing the stories of and the demands of the vulnerable population.
Thank you very much, Shweta. The health rhetoric, as during one of the opening plenary session, heat is held, air pollution is held, nutrition is held. We are in the air pollution session, but we need to know all the actions we are taking as solutions are driving towards health. And this is the model we are using in Cameroon, where we don't want to make people feel that there is a disconnect with the ministries and health. People at Ministry of Transport, they suffer from health-related issues, air pollution. People at the Ministry of Agriculture, they suffer, and that is why we feel health should be cutting across all of them. The final question will come to Prof. Eba, where we will be looking at what role should international funding organizations play in helping low-middle income transition from cleaner energy, household and energy sources. So, like, what do you feel international funders should focus on in low and middle income countries to really clean indoors for cleaner air? Because if we clean the air indoors, then we are going to transition to making everywhere to be clean if we have clean air indoors.
Yes, I don't think I'm the right person to say what kind of funding is needed in those countries, but I could say what kind of funding I would have wished for more in the research. And I think it's important that in those countries, a lot of the environmental health legislations come from court cases. And we don't really have the funding to support those, because often we get funding to do epidemiological studies and they take a long time, but they are not always targeted toward supporting these court cases, and that would be something that I would have loved.
Yeah, thank you very much. We are come to the end of our session, which was really engaging. And I want to thank all the speakers, Lisa from Cameroon, Shweta from India, and Eba from Sweden, which I want to thank you all and thank all of the participants. It was a massive contribution.